Yes, sir. Now it is okay.
Yeah. So sorry for the disruption. So type 1 diabetes. So it is an autoimmune disorder mainly caused due to destruction of pancreatic beta cell. So due to destruction of pancreatic beta cell, insulin will no longer will be produced, and due to due to non-availability of insulin, it may lead to hyperglycemia, ketoacidosis, and potentially death may occur if a patient will not be treated with insulin. So there are various treatment goals for achieving the normal blood glucose, that is by giving insulin, as well as if insulin will be given to the type 1 diabetes, there will be avoidance of long-term complications. So it is the second most common chronic disorder which is associated with childhood, and peak age at the onset it is around puberty. But type 1 diabetes can occur at any age, and incidence is increasing worldwide approximately 3% per year. If we are saying the incidence of type 1 diabetes, it is highest in Finland and lowest in Mexico. So there are various environmental risk factors. So seasonality at the diagnosis, migrants assume risk of host country, and there are various risk factors which are associated from case studies. So in that first, that is infant as well as childhood diet, virus exposure, hormones, stress, improved hygiene, and vitamin D. So concordance in the incident in the identical twin is always greater, that is monozygotic versus the dizygotic twin, and 15-fold increased the risk for first degree relative. When we are comparing the risk, it is almost 6% through the age of 30 years, and risk increases in presence of susceptibility of the genes. So most of the time what will happen, the type 1 diabetes, it is an autoimmune disorder, and antibodies will be produced which will destruct the pancreatic beta cell, that is functional beta cells, which are mainly responsible for the release of insulin. And mostly the occurrence of type 1 diabetes is always in the childhood ages, and that is mainly due to the susceptibility of certain genes. When we are talking about the MHC region of chromosome 6p21, that is major histocompatibility region of 6p21. So chromosome number 6 in that 21 is the 21. So what exactly will happen? This gene is mainly related with the immune system or the immune modulation. So predisposition to type 1 diabetes is better determined by haplotypes. So DRB1 and DQB1 haplotypes are more accurately determine the type 1 diabetes risk. So DRB1 and DQB1, these are the chromosomes as well as the haplotypes which will be responsible for testing, or those genes or alteration in the genes may lead to the type 1. So testing for both the genes, that is DQA1 and DQB1, is slightly expensive. Means if we want to go for the alteration in the gene sequence of those mentioned DQA1 and DQB1, then it is a quite expensive method. So high risk type 1 haplotypes are DQA1 0501 and DQB1 0201. Another gene which is associated with the risk of type 1 diabetes, that is DQA1 0301 and DQB1 0302. So when we are talking about relative incidence in type 1 diabetes risk by the number of high risk haplotypes, so ethnicity, that is DQA1 and DQB1 we are compared. So here ethnicity is 2:1. When we are saying the relative risk of those genes in Caucasian, that is DQA1 is 16 while DQB1 is 4. African American, it is 45 and 7, while in Asian, it is 11:4. So when we are having this data, and we will able to know that it is having more prevalence in African American and less in Asians.
Wait. Hello?
Yeah. So absolute risk of type 1 diabetes to the age of 30 by number of high risk haplotypes. So when we are saying this number of high risk associated with the genes, that is DQA1 and DQP1 haplotypes. So ethnicity 2, 1 and 0. And when we are saying the prevalence of alteration in the gene, that is Caucasian, African American and Asian. So it is again more in African American as compared to the others. So amongst all these groups, Asian people or Asians are having less prevalence of type 1 diabetes, which is associated with high risk haplotype of DQA1 and DQB1. So risk of developing type 1 diabetes, it is 25% with two of them, that is DQA1 and DQB1. When there is an alteration or mutation or deletion in those genes, the maximum chances will be of development of type 1 diabetes, and 8.3% only associated with either DQA1 or DQB1. And if there is no alteration in DQA1 and DQB1, there is a prevalence of 1%, and there will be less chances, but other contributing factor may responsible for the development of type 1 diabetes. So these are the genome screen for type 1 diabetes. So IDD, that is insulin dependent diabetes, M1, M2, M3, and these are the specific chromosomes at which there will be either addition or deletion. But most of the time there will be a deletion which may result into certain immune response, or that may be associated with either the longer chain of chromosome or shorter chain of chromosome. And what exactly the things, that is Q is the shorter chain, P is the sorry Q is the longer chain while P is the shorter chain. The first digit, that is 6, 11, 15, it indicates the number of chromosome, and the alteration which taken place, that is the
Manoj, sir, your voice is not coming now. I think
some technical issue.
yes.
We'll be back.
Yeah.
yeah. So these are M1, M2, M3, M4, up to
Manoj,
yeah.
you have to make again presentation.
Sir, your presentation is gone. You have to share the presentation again.
Okay. Yeah, just a minute. Sir, now it is visible.
Yes, sir. Yes, sir. It
Yeah.
is.
So there are various genome which will be responsible for screening of type 1 diabetes. So in that M1 to M13, M14, M15, M17, M18, then PTPN22, VDR, interferon alpha, sorry, interferon gamma, and TGF beta 1, that is tumor growth factor beta 1. Then insulin dependent diabetes mellitus M2. So when we are talking about insulin gene, that is chromosome 11p15. So variable number of tandem repeats, that is class 1, class 2 and class 3. In class 1, the repeats were 26 to 63. In class 2, it is approximately 80 repeats. In class 3, 141 to 209 repeats, and relative increase in the risk, it is 2 times greater as compared to class 1 ally. Okay, so when we are having the class 2 and class 3, the repetitions are more, so the relative risk will be more. So class 1 is associated with lower mRNA in the thymus that may reduce tolerance to the insulin and its precursor. So as all we know that type 1 diabetes, it is an autoimmune disorder where the antibodies will be produced, and those antibodies will destruct the functional beta cells, and due to those degradation or destruction of pancreatic beta cell, a person may develop type 1 diabetes. So when we are talking about, or when we are comparing class 1, class 2 and class 3, the class 1 is associated with lower mRNA in the thymus, so that which may reduce the tolerance to the insulin and its precursor. So IDD M12, that is cytotoxic T lymphocyte associated 4, CTLA4, and chromosome 2q33. So it encodes a T cell receptor that plays a role in T cell apoptosis. So that may be THR 17 ALA and relative increase in the risk, that is 1.2 per 1.2, means what will happen if there is an alteration in the IDD M12 genes. So in that case, what will happen? The risk will increase up to 1.2 fold, and dysfunction of CTLA4 is consistent with development of type 1 diabetes. So CTLA4, that is nothing but cytotoxic T lymphocyte associated 4. Then when we are talking about PTPN22, lymphocyte specific tyrosine phosphatase. So chromosome 1p13 encodes LPY, that is important in negative T cell activation and development. So this is mainly responsible for alteration and binding of LYP to cytoplasmic tyrosine kinase, which regulate T cell receptor signaling kinases. So as a pharmacologist, as most of the students or faculties, so all we know that there are various pathways, that is tyrosine kinase, tyrosine phosphate, as well as GP, means there are various signaling pathways. So in that case, what will happen? Cytoplasmic tyrosine kinase, which is mainly responsible for T cell receptor signaling kinases. So intervention trial for T1D, that is type 1 diabetes. So intervention, that is TZIGR, DIPP and trial net. So intervention is avoid CM, insulin and immunosuppressive agent. So target is FDR, GP genetic and FDR antibodies and genetics. So when we are having CM, that is cow milk, and insulin given which is by the nasal route, is mainly means insulin which is given by nasal route will be shown effective treatment, it shows effective action in the treatment of type 1 while first degree relative and GP is the general population. So natural history studies for type 1 diabetes, which is conducted in the general population, Daisy, Colorado, then Panda, Florida, and Teddy, US and Europe. So based on newborn genetic screening, that is the proper information consent, and parent are notified the result by giving on male, and general population at high risk, that is 5 to 8% recruited for follow-up, and more than 50% of children who will develop type 1 diabetes will not be eligible. So in that case, what is the thing? Most of the time, whatever the wards or whatever the children, they are screened for type 1 genome screening. So whatever the data we are getting or the data which is received, that will be kept confidential, and that when we are assess the risk, that is most of the time general population, they are at the higher risk for development of type 1 diabetes, and the prevalence is around 5 to 8%. So genetics and prevention of type 1 diabetes. So type 1 diabetes cannot be prevented because all we know that it is an autoimmune disorder. The prevalence or the severity may be reduced by giving some of the immunosuppressant drugs, because immunosuppressant drug, what they are mainly responsible for suppressing the T lymphocytes, and the immune response will be suppressed, and there will be no further degradation or destruction of beta cells. So education programs are need for parents for those children who are suffering from type 1 diabetes. Then we will move towards type 2 diabetes. So all we know that type 2 diabetes is also called as non-insulin dependent diabetes mellitus, and is a group of genetically heterogeneous metabolic disorder that causes glucose intolerance. So in type 2 diabetes, pancreatic beta cells are present, but their efficiency will be reduced. And those, due to reduced insulin secretion, a person may develop insulin resistance. So approximately 90% of the individual with diabetes have type 2 diabetes, may be treated with diet, oral medication, physical activity, and the person who is suffering from type 2 diabetes may be asymptomatic for many years unless and until the glucose level will not be estimated, and associated with long-term complications such as neuropathy, nephropathy, retinopathy, or microangiopathy. So all we know that various factors which are, various factors, so they are genetic factor, environmental effects, increase in the fatty acid level, and increased blood glucose level. So most of the time, a person who is suffering from type 1 diabetes, so will, again there will be no glycemic control. Then second, environmental factor like exposure to various chemicals, mutagens. Then in hyperlipidemia, if we are talking about hyperlipidemia due to elevated level of TG as well as total cholesterol, a person may develop resistance to the insulin, and there will be no proper insulin regulation. And finally, what will happen if there is decreased concentration of insulin in the blood, which may affect the blood glucose level, and there will be increase in the blood glucose level, which may result into insulin resistance, and finally complications associated with diabetes. So there are various genotypes. So in primitive type, individuals who are metabolically therapy were able to store high proportion of energy as a fat when food was plentiful, more likely to survive times. In recent years, a continuous supply of calorie dense processed food and reduced physical activity. So what is nowadays, due to change in the lifestyle as well as calorie dense processed food like fast food, this also changed the better glycemic control and due to reduced physical activity, because in type 1 diabetes burning of calorie and physical activity is necessary. So due to reduced physical activity, again there will be development of insulin resistance, and these changes are likely to explain rise in the type 2 diabetes. So type 2 diabetes, all we know that glucose, fasting blood glucose and random blood glucose. So fasting blood 70 to 100 and random blood glucose when it is more than 140 milligram per deciliter. When we are talking about the type 2 diabetes prevalence worldwide, in Indian it is highest, and when we are seeing it is lowest in the Poland, because most of the time India is a developing country where there will be changes in the lifestyle as well as due to day to day lifestyle, there will be a maximum chances or uh, there will be more chances of development of type 2 diabetes. So estimated number of adult with diabetes in developing country, as we know India is a developing country, so the estimated number of people who are suffering with type 2 diabetes up to 2030, that the development of type 2 diabetes will be more in the age group that is 45 to 64, and it is lowest amongst 20 to 44. In developed country, if we are saying most of the time 20 to 44, 45 to 64 and 65. So in developed country, the prevalence of type 2 diabetes is more after the age of 65, because in India, most of the time what will happen, the type 2 diabetes remain undiagnosed and the patient will develop severe hyperglycemia along with certain complication, and the diabetes will be detected at a very later stage, and at that time to control or to have a better glycemic control, it requires more time. So most of the time in India, the affected population will be in the group of 45 to 64. So nowadays there will be increase in the prevalence of type 2 diabetes in children also. So those parents who are suffering from type 2, their children may have a chance to develop type 2 due to genetic predisposition. So environmental risk factor in type 2 diabetes, obesity. Obesity plays an important role in development of type 2 diabetes, and it is mainly due to development of insulin resistance, and around 80% of newly diagnosed cases of diabetes, that is mainly due to obesity. That is physical activity. Lack of physical activity also results into development of type 2 diabetes, and if we are going for better physical activities such as exercise, which will control the weight, improves glucose and lipid metabolism, which is inversely related to the BMI. So most of the time, impaired glucose tolerance in type 2 diabetes is approximately around 60%. And if we are modifying the lifestyle intervention, that may result into reduction in the glucose tolerance. Okay, and that is around approximately 60 to 70%. So when we are talking about genetics, when we are talking about genetics and type 2 diabetes, individual with a positive family history are about 2 to 6 times more likely to develop type 2 diabetes than those with negative family history. So there is a genetic predisposition, and those genes will be carried to the next generation, and the parents who are suffering from type 2 diabetes, their children is having more chances for development of type 2 diabetes. And for this, risk is approximately 40%. And if parents are suffering from diabetes or they are having diabetes, the chances of development of type 2 diabetes in children's or in adults or in their childs is approximately 80% if one of the parent they are suffering from diabetes. So higher accordance for monozygotic twins versus the dizygotic twins. So it is mostly observed in monozygotic as compared to dizygotic. Has been difficult to find the genes for type 2 diabetes, late age at onset, polygenic inheritance, and multifactorial inheritance. So what are the genes candidates selected because they are in, what are the genes involved for the detection in type 2 diabetes? So these are because they are involved in pancreatic beta cell function, insulin action, energy intake, and lipid metabolism. So most of the time, those genes are related with the pancreatic beta cell and those genes which are mainly responsible for lipid metabolism. Maybe they are associated with PPAR gamma, and the prevalence of type 2 diabetes, it is having a correlation with PPAR gamma, that is peroxisome proliferative reactivated receptors, genome wide screen. So there is a nothing to be assumed about the disease and etiology. So we are not aware about the exact etiological factors. So it becomes a difficult for finding a particular gene for type 2 diabetes and genome wide associated studies. So what are the various challenges in finding out those genes? So these are inadequate sample size, multiplex families, causes and control, difficult to define the phenotype, reduced penetrance, influence of environmental factor and gene-gene interaction, variable gene at the onset, failure to replicate finding, and gene identified have small effects. Means at the end of study or at the end of genome screening study, a faulty genes will be identified or those genes which are not having a particular impact in development of type 1 diabetes. Just a minute, sir. I think it has been disconnected.
Yes, sir, your presentation is gone again.
Yeah, just a minute, sir. Maybe network issue, I think.
No problem, no problem.
Yeah, now it is visible, sir.
Yes, sir, it is visible.
So most of the time what will happen at when a genome screening has been conducted, the genes, whatever the genes identified, they are having a less impact and small effect. So due to that reason also, that is also one of the challenge for finding a particular gene which is responsible for development of type 2 diabetes. So CAPN10 NIDDM1. So chromosome 2q37.3, it is mainly responsible for encoding and intracellular calcium dependent cytoplasmic protease that is ubiquitously expressed. So all we know that most of the time drugs, they are mainly responsible for opening of calcium channel, and these calcium channels are responsible for exocytosis. So the process of exocytosis means due to that reason insulin will be released, and this insulin will be responsible for regulation of blood glucose. So due to this protease, that is chromosome 2q37.3, it will be expressed and may modulate the activity of enzyme or apoptosis. So there is a programmed cell death, and due to that reason, there will be a chances for the NIDDM and likely to involve in insulin secretion and resistance. So just now I told you that calcium means calcium ion channels are mainly responsible for regulating the contraction, and if there will be no proper regulation of calcium inside the cell, the process of exocytosis will be affected. And sometimes what will happen, there will be development of resistance, that is mainly due to insufficient release of insulin, and due to insufficient supply of insulin, there will be a chances of development of resistance. So stronger influence in Mexican American than other ethnic group, and it is responsible for approximately 40% of familiar clustering. Familiar clustering means those parents who are suffering from type 2 diabetes, there may be a chances of development of type 2 diabetes in their wards. So genetic variants associated with this, that is A43G, THR, 50ALA, and PHE 200 THR, and estimated relative risk is approximately 2%. Then PPAR gamma. So peroxisome proliferator activated receptor gamma, that is chromosome 3p25. So transcription factor, they plays an important role in adipocyte differentiation and function. So alteration in the PPAR gamma may result into difficulty in differentiation, and adipocyte will not function properly. So it is associated with decreased insulin sensitivity. Means PPAR gamma modulator, what they will do, they will reduce insulin sensitivity or insulin resistance, but due to alteration in PPAR gamma, that may be results into insulin resistance. And target for hypoglycemic drugs such as thiazolidinediones, mainly the rosiglitazone as well as thiazolidinedione. So genetic variant pro 12 ALA and pro E risk alive common, and relative risk is 1 to 3%, and it is most common. So PPR gamma alteration in chromosome chromosome 3p25, there will be a chances, means approximate 25% chances of development of type 2 diabetes. So ABCC8 and KCNJII. So ATP binding cassette subfamily C member rate of chromosome, that is 11p15.1, and second one is potassium channel inward rectifying subfamily J member 11. So chromosome 11p15.1. So ABCC8 encodes the sulfonylurea receptors. Okay. So most of the time sulfonylurea, what they will do, they are mainly responsible for degranulation of pancreatic beta cells. Degranulation of pancreatic beta cells, and due to degranulation of pancreatic beta cell, release of insulin will take place. So it's coupled with KIR 6.2 subunit and part of ATP sensitive potassium channel, mainly involved in regulating insulin and glucagon release. So mutation affect channel activity and insulin secretion. So mutations associated with ABCC8 may result into the alteration in the activity of channel and insulin secretion, because most of the time what will happen, the beta cells are mainly responsible for release of insulin, but due to alteration or deletion in the gene sequence of ABCC8, it may affect release of insulin. Means insulin will be released, but to the less extent, which may develop into type 2 diabetes. And most of the time ABCC8, this is the site for action of sulfonylurea, that is one of the oral hypoglycemic drugs. And genetic variants, that is serine 1369 alanine and glutamine, 23 lysine respectively, and the relative risk that is 2 to 4%. Means the alteration in the gene sequence of ABCC8 and KCNJII, the relative risk is around 2 to 4%. It is very less. Most of the time, the alteration in the gene sequence is very occasional. Then TCF7 L2, that is transcription factor 7 like 2, that is chromosome 10q25. So it is related to impaired insulin release of glucagon like peptide 1 and reduced beta cell mass or beta cell dysfunction. As as type 2 diabetes is mainly due to reduced insulin secretion. So reduced insulin secretion may be due to the defect in beta cell, or second thing, genetic predisposition, or third thing, reduced beta cell mass, and fourth one is, as already we seen with the last, that is alteration in the potassium channel and calcium channel. So stronger amongst all means it is a stronger amongst lean versus obese type 2 diabetes. So most of the time 10% of individual are homozygous, and they have twofold increase in the risk relative to those with no copy of the variant, responsive to sulfonylurea, not to the metformin, because these these receptors, they are mainly responsive to sulfonylurea and not to the metformin, because most of the time metformin will be responsible for peripheral utilization of glucose. Means metformin activate or metformin is mainly responsible for peripheral utilization of glucose. It is not having any action of functional beta cells. And genetic variant, that is RE7901694 and other in LD, and estimated relative risk, that is approximately 1.4% due to deletion of some of the genes associated with TCF7L2. GWAS new loci identified, that is FTO chromosome 16q12, fat mass and obese associated genes. So in previous slide, I told that most of the patient or most of the people who are suffering from obesity, the prevalence of development of type 2 diabetes is more, and it is associated with chromosome 16q12, and governs energy balance. Gene expression is regulated by feeding and fasting, and the estimated risk in the alteration of this chromosome 16q12 is 1.23%. Then another, that is HHEX IDE chromosome 10q23 or 24 near to TCF7L2. So hemopiotically expressed in hemobox transcription factor in liver cell and insulin degrading enzyme IDE, that is insulin degrading enzyme. So due to alteration in this gene or in this gene, a specific enzyme will be produced, which is a proteolytic enzyme, which may degrade the action of insulin by hydrolysis. Means once the hydrolysis of insulin will takes, there will be terminating in the action of insulin, and that is mainly associated with IDE, that is insulin degrading enzyme, and having affinity for insulin and inhibit IDE mediated degradation of other substances, and having the relative risk of 1.14%. Then another gene, that is CDKAL1 chromosome 6p22, that is cyclin dependent kinase regulatory subunit associated with protein 1 and likely to plays a role in CDK5 inhibition and decreased insulin secretion. So ultimately what will happen, due to reduced insulin secretion, there will be development of type 2 diabetes, and the risk is around 1.12%. Another gene SLC 30A8 chromosome 8q24 solute carrier family of 30 zinc transporter and may have major autoantigen for type 1 diabetes. So the risk again it is 1.12%. Then IGF-2B 2B P2 chromosome 3q28 insulin like growth factor 2 mRNA binding protein 2 regulates IGF2 translation, which may stimulate insulin action, and estimated relative risk is 1.17%. The next one is CDKN2A/B chromosome 9p21. So cyclin dependent kinase inhibitor 2A, and it plays an important role in pancreatic development and islets proliferation. So due to absence or due to deletion of this gene may result into hampering in the development of pancreas. As we know that pancreas is having both exocrine and endocrine function, and the endocrine function of pancreas is mainly responsible for release of various hormones such as insulin, glucagon, pancreatic polypeptide, and this deletion of genes may also having a specific effect on islets proliferation, and if islets proliferation will not take place, there will be no release of insulin for insulin from pancreatic beta cell, and the relative risk for this gene deletion is around 1.2% for the development of type 2 diabetes. So type 2 genes are a drug target, that is PPAR gamma, ABCC8 and KCNJII. So drug used routinely in the treatment of type 2 diabetes and pharmacogenetic implications. So already I told that thiazolidinediones as well as sulfonylurea are the targets for those genes which will be responsible for giving a prominent effect, and response to oral agent may be related to one's genotype, and genetic testing may be responsible for identifying individual at a high risk for type 2 diabetes and guide for treatment regimen for type 2 diabetes. Means if we are going for screening of those genes or alteration or deletion in a specific chromosome, then we will able to identify a specific target, and once the target will be identified, it will be very easy for giving a specific treatment for type 2 diabetes, that is pharmacogenetic approach and individualization of therapy. So based on age, body weight, sex, as well as ethnicity, we will able to give a specific drug for the treatment of type 2 diabetes. Genetics and prevention, that is type 2 diabetes is preventable, and there will be various preventive measures. In that first one, maintaining a appropriate body weight, exercise, then new genes or screening will provide insight into the etiology, what are the exact cause of type 2 diabetes, where addition or deletion takes place, or what are the mutations, or where is the absence of specific genes in which chromosome will give us the exact idea into the cause of diabetes, that is genetic etiological cause of the diabetes. Then public health message and having the genetic testing. So challenges include predictive value of most of the test is low. How to communicate risk information, means even if we are identifying a specific gene, then it is unpredictive, or it means how we have to communicate with the patient and what is the risk associated with that particular gene for specific information. Then healthcare professional may not be able to interpret genetic test. Most of the time what will happen, even if you are going for detection of certain genes, which may be responsible for development of type 2 diabetes, the health practitioner will not able to correlate those results with the development of disease. For that, we need a specialized molecular biologist, molecular biologist. They may correlate the data and will be able to help to the health practitioner for the prescription of suitable drug for regulating the proper glycemic control. Then genetic testing may lead to distress. Some of the time what will happen after getting the result, the person may think that maybe he is having a deficiency of certain genes, or sometime due to addition or deletion, that person may have the phobia that he may develop cancer in future. So there are certain distressing factors which will get through genetic testing. Then insurance and employment discrimination, confidentiality, and direct to consumer marketing for genetic testing. So these are some of the challenges which may be associated with the genetics. The last one, that is maturity onset diabetes of the young. So it accounts approximately 5. Sir, I'm having time 5 to 10 minutes. Hello.
Yes, sir.
Yeah. So it accounts for approximately 5% of type 2 diabetes, which may result into single gene defect. So autosomal dominance, inheritance, or multiple generation affected. So early age of onset, that is 25 years, characterized by absence of obesity, no ketosis, and no evidence of beta cell autoimmunity. So maturity onset, it is not due to obesity or due to beta cell autoimmunity. So hyperglycemia is often corrected by modifying the diet. So these are some of the genes which are associated with maturity onset diabetes: Y1, Y2, Y3, Y4, Y5, Y6. These are the specific genes: HNF4A, GCK, HNFA, HNF1A, IPF1, HNF1B, NEUROD1, and these are the proteins: hepatocellular nuclear factor 4 alpha, glucokinase, hepatocyte nuclear factor 1 alpha, insulin promoting factor 1, hepatocyte nuclear factor 1 beta, and neurogenic differentiation factor 1. So mutations around 12 mutations, approximately 200. So when you are seeing it is highest in the glucokinase, that is the loci 7p15 p13, and the gene which is responsible for mutations, that is GCK, and approximately 15%. So 65% of maturity onset diabetes is associated with MODY3 HNF1A gene of chromosome 12q24.2. Maturity onset diabetes in young, one is HNF4A. So transcription factor, it is expressed in liver, kidney, intestine, and pancreatic islets, and has been associated with type 2 diabetes. So it is mainly responsible for it controls gene involved in glucose, cholesterol, and fatty acid metabolism. So this transcription factor will control genes which are involved in glucose, cholesterol, and fatty acid. So due to mutation in those factor, or in those transcription factor, there will be improper regulation of glucose, cholesterol, and fatty acid metabolism. Controlled transcription of HNF1A and several mutation splicing defect identified, which will account approximately 5% of all maturity onset diabetes in young cases. Then another that is glucokinase, only MODY gene, that is not a transcription factor and required for glucose metabolism, along with insulin secretion. So it will be acting as a glucose sensor. Glucokinase is acting as a glucose sensor. So MODY2 is generally a mild form of diabetes. So approximately 200 types or 200 mutations have been identified with this gene, and VNT are nonsense and missense mutations, which will account for approximately 15% of the cases. So next one is hepatocyte nuclear factor 1 alpha 12q24.2. It regulates expression of insulin and other genes which are involved in glucose transport along with glucose metabolism. So if glucose will not be transported to RBC, liver as well as muscles, there will be increase in blood glucose level. Due to improper metabolism of glucose also, a person may develop into diabetes and results in a severe insulin secretory defect, which may contribute to abnormal islet cell development. Another impact of mutation in the said chromosome, that is 12q24.2, may result into abnormal islet cell development and severe insulin defect. And more than 100 genetic variants have been identified which are associated with MODY3, and mutation in MODY3 are most common causes of maturity onset diabetes in the young, which accounts around 65% in the total cases. And next one is transcription factor that regulate expression of insulin, somatostatin and other genes, mainly MODY4, that is insulin promoter factor 1 on 13q of 13q 12.1. Mutations leads to decreased binding activity to the insulin promoter, and due to that reason, reduced activation of insulin gene is response to the glucose. If insulin gene will not be encoded, there will be no proper release of insulin, which may have improper glycemic control. And genetic variants include friendship, insertion, and missense mutation. So most of the time, either there will be addition or complete deletion, and missense mutation, and accounts for very small portion of maturity onset diabetes in the end. So whatever the mutations which are associated with MODY4, that is insulin promoter factor 1, they are least amongst all other gene mutations. Then MODY5, that is hepatocyte nuclear factor 1 beta, required for the transcription and expression of variety of gene, and it is highly homologous to HNF1A, which recognize same binding site as HNF1A, which regulate gene expression, and individual have lower renal threshold to the glucose, and it rarely causes maturity onset diabetes mellitus. Then next one is MODY6 is a transcription factor involved in the differentiation of neurons, regulate insulin gene expression by binding to the critical motif on insulin promoter side. And few genetic variants, that is missense and nonsense mutation, and account for approximately 1% of all maturity onset diabetes in young cases. So summary, just I want to give you a summary for this maturity onset diabetes. So these genes are expressed in pancreas and play role in metabolism of glucose, regulation of insulin or other gene involved in glucose transport, and development of fetal pancreas. So most of the time, these genes are mainly associated with regulation of glucose metabolism. If faulty metabolism will be there, there will be no proper glycemic control. Some of the genes which are involved in transportation of glucose to kidney, liver, muscles, RBC, and due to affecting the glucose transport, there will be no proper check in glycemia, And the last one, that is development of fetal pancreas. If pancreas will not develop properly, there may be a chances, or there will be a chances, that is the proliferation of pancreatic beta cells will not be proper, which may hamper release of insulin in later stage. So MODY phenotype depends on MODY genotype, and knowing to genotype is important determinant for treatment. So these are the treatment strategies for MODY phenotypes, complications and treatment. D for diet, O for oral agent, and I for insulin. So most of the cases, so MODY6, it is severe and requires, that is a diet and oral agent should be given for a better glycemic control. While some of the cases we need insulin injection for having a better glycemic control. Thank you. So I would like to thank. So I would like to thank Dr. Ajit Singh, Dr. Salahuddin sir, Swati Mittal ma'am for inviting me and giving a talk on genetic variants in diabetes and